And I wanted to take us back first to telehealth and ask two questions, and maybe don't all speak at once. But the first is, we know something about telehealth utilization in recent years, and we can segment it by socioeconomic status and age. Question is, and Preeti, I'm going to start with you. What do we know about the quality of that care? What do we know anything about outcomes? So that'll be question one. And then maybe after you, I'd like to look to the others to weigh in on. Well, you can also feel free to weigh in on. What are the barriers going forward to maintaining the appropriate adoption of telehealth? Medicare payment comes to mind, regulatory issues, state lines. But go where you want to go on that one, Preeti.
Yeah, thanks, Murray. I'm reflecting on it, both as a family member and as a clinician, and then again with some of the data, which a lot of people were very interested. So I shared the links to the telehealth report. I'm not aware of a systematic approach to sort of addressing quality of care. And, in a sense, the people who are seeking care this way, there's actually multiple buckets. I mean, some are like, this is great, I'm busy, especially I think in the mental health space. It's really opened up opportunities, particularly for younger adults, like who can take a break from work and see their therapist and get back. But one thing I wanted to point out is I think there's a big difference, and a few people asked this about video versus phone visits, and it's an equity issue. It's a technology comfort issue. It's, not everyone's got Wi-Fi, not everyone's got a laptop. People are using their phones, but that's one that I think we could do more work on to try and improve, because as a clinician, I think there's a big difference for me seeing somebody and like just talking to them on the phone. I mean, talking to them on the phone, it's not even like a visit in my mind for a lot of things. But it's very interesting because it's not just follow-up care or like post-operative care. We're seeing like very complex patients who are entering the system this way. And I'll just share that my partner is a head and neck surgeon, and he says to me, he's like, I've really gotten good at this. It's interesting. He's like a clinician's clinician. He's of course, I'm very proud of him, but he says, I've gotten so much better at this, doing this a lot. And I think he's not alone in that we're all getting better at it. And I think the way we're providing care is different, but that'll be a really great area to study.
Yeah, I've heard similar things from our orthopedic surgeons, that they're sort of amazed at how much of their job they can do through telehealth. Eventually, you got to put the pin in, but you can get a lot of work done. I've also heard that for video that there are HIPAA issues that are not present there with audio, and I don't know if anybody wants to speak to that. And correct me if that's not true. Okay. No biting. So, well, let's talk about payment and regulatory. Ipsita, do you want to weigh in? And Desi, maybe your former CBO hat or OMB hat?
Sure. On which aspect of payment? For telehealth?
Yeah.
So, the PHE, or the public health emergency, is slated. So they haven't actually announced this officially, but I know that the 60-day count started about a week and a half ago, which is then supposed to trigger the winding down of the public health emergency. The initiation of the PHE triggered a slew of waivers and allowances for providers, clinicians to see patients via various media, so phone, as well as video. One thing, perhaps, I think, Murray, that's important to highlight is why there had been hesitation in the first place. Any of us who've been at MedPAC or any of the policy organizations do not assume that every provider, every clinician is a good actor. You just learn that that's not the case. And so utilization sometimes is not indicated. It's not necessary. And you just have some bad actors, and bad actors tend to trigger a reaction, if you will, from policymakers. So that has colored, because we know that has colored for a long time how policymakers viewed the use of telemedicine in healthcare. There were simply no reliable mechanisms to manage utilization until it had already happened, and then you're basically chasing the provider. The public health emergency was an opportunity, whether intended or not, to test, because people really needed a way to see their physicians and to get care. To test whether this works, and it did. A lot of Medicare beneficiaries, a lot of individuals, myself, probably all of us here, were able to get a lot done in terms of our maintaining some continuity in terms of our primary care. Behavioral health took off because it's easiest to do. So the accessing therapy, talk therapy services, getting prescriptions refilled was easier to do relative to some other specialties. And so we see a clamoring of maintaining, these policy routes, if you will, to continue to pay for telehealth visits, because we would rather have them than not. So I think what we will see is some meeting of the minds, if you will, some medium point where some visits will be allowed. CMS, I know, is doing a lot of policy work. CETA may be keeping a closer track on this, so that we don't have a complete sort of, retreat, because I don't think that's going to happen. The cat is out of the bag. And we are expecting that post PHE, there will be significant allowances in the use of primary telehealth for major areas of healthcare.
CETA, anything you want to add?
Yeah. So, I mean, a couple of things. One thing that it does mentioned is very true. You have the physicians who are, perhaps gaming the system. Again, there are always bad actors, but then, calling a lonely Medicare beneficiary to kind of see how they're doing, and then billing that as a right, trying to get reimbursed for it. And that ties it into the audio only discussion we were having a minute ago. But I think you're right, like with the 3940 waivers that were granted at the beginning of COVID, we're likely to see a 1 or 2 year extension of those, because telehealth has been so amazing, particularly on the behavioral health side. And I mean, I think what you'll hear from the companies is, there's a place for it, for the televisit to complement the physical visit. But then you're also seeing, at least in the public markets, I know Adez works in the private markets, Teladoc, Amwell, some of those stocks really have kind of tanked, if you will, as folks are going back to see their doctor and getting procedures and so on and so forth. But there certainly is a place for it. I know I finally had a physical, good Lord. And the lady said, look, when you're, she said, when your blood work comes back in, let's just do a televisit. She's like, you don't have to come back and, drive 20 or 30 minutes to see me. And I'm thinking to me, that's a great use of the in-person visit being augmented by the video visit.
Yeah, we've had a lot of success for years now with that, because no co-payment, no drive, no finding a parking spot. You can't do everything that way, but you can do a lot of things that way. Lemore, you provoked a number of reactions in the chat. Where to start? I guess I'm going to ask one question. I don't know if it was in the chat, but when you were looking at geographic variation, and you had 10th median and 90th percentile, what do we know about those 90th percentile hospitals, and are they the same year after year?
Someone knows. I don't know. Which won't
HCC
stop me
knows,
from
right?
speculating. The data are from the Healthcare Cost Institute, those specific distributions, and they were constructed using the universe of claims from United, Aetna, and Humana, and many Yeah, so not the Blues, who are a really key and omitted player. So in terms of the persistence of pricing over time, my exposure to hospital contracts leads me to think, yeah, pretty persistent over time, because you usually base your rates on last year's rates plus, but I can't affirm that from the data. I think a related question, Murray, that I suspect prompted yours is, well, are you getting a much better patient experience and or higher objective quality patient reported outcomes from that? And there is a little bit of debate on it. I say a little because most studies have not found that merger induced or no studies have found that merger induced price increases have led to measurable quality improvements. I have one that finds modest reduction in patient experience. But there is one working paper out by colleagues at Kellogg that finds that higher priced hospitals have higher quality based on, you know, a range of outcome and satisfaction measures. Now, I would say that, of course, I would say they should. We shouldn't actually, that should be a baseline. But just to note there that there is far from consensus about whether price caps would have any meaningful impact on quality.
Yeah, and hard to adjust for patient acuity and all the other things that go with that. You know, I think it's also worth calling out that, you know, those high prices get shared with a lot of the people in the system, and so they lead to higher, you know, collective bargaining contracts and everything else. And it's caps are not easy. A related issue that came up, and it was the chart you had comparing commercial rates to Medicare rates, is that cost shifting?
Oh, yes. I did see that question in the chat and thought that would take too long to try to type out an answer.
You can just say no.
So the research on, so what is cost shifting? Cost shifting is this argument that the reason that private prices are high is because the government is not paying its fair share to cover its spending. What I can tell you is that empirical research that looks at what happens when you increase or decrease Medicare or Medicaid payments to private prices does not see, we don't find causal evidence of those things. Another kind of, I would say, compelling point besides just the data work doesn't support that argument is the executive director of the Massachusetts Health Policy Commission told me when I said, you know, when I talk about potential price caps, even at the extremes, I hear this, well, the government's not covering for our Medicaid patients. He says, you know who you hear that from? You hear that from the providers that have the least Medicaid. And that is interesting. Part of the, right, that to the extent that the high costs they have are because they have high prices. If you had lower prices, there is evidence that that brings down costs, and therefore your shortfall, if you will, would not be as extreme.
Thank you. Anybody else want to weigh in on that issue? We have endless debates about cost shifting, and I think for those who don't know, the economics profession is pretty unanimous on money doesn't get left on the table. Adeze, this came out of your presentation, but I think it generalizes. And again, coming from an integrated delivery system, I'll just put my bias on the table. But one of the things that I hear from our providers is that, you know, all these sort of pop-up teledocs or other kinds of services, are we, you know, is that leading to fragmentation of care? Just sort of where you're seeing one provider for one issue, another provider for another issue, nobody's actually managing the patient. Do any of you have thoughts there? Preeti, you might, how do you think about this? Or do you share that concern?
You know, I think I will say that I think it's gotten a little better with shared electronic health records, you know, technology compared to like, and again, I'm a subspecialist infectious disease physician at a very specialized tertiary care hospital. And, you know, it was very common, you know, people would come to our hospital transferred on a Friday with no records,
Mhm.
and, that piece I think is better because I can get information in a way that I can control, like just with a shared record. But this is something where I think vulnerability, whether it's English as a first language, whether it's socioeconomics, whether it's transportation, it's going to be magnified for people, and it's challenging because there's so many pressures on clinicians, physicians and other clinicians in terms of just getting through and like doing all your documentation, to like really call people and do the follow-up. But I think this is where, and again, Murray, I think, the systems in California have really led in a lot of ways, and, the integrations, that this is a place for benefits. And I think the one piece I might reflect on is like with my own parents who are in a really good Medicare Advantage program. And in also, actually not my system, even though they live nearby, and not my brother's system, even though he lives nearby, but a system they've had care in for years, and all their providers are there. I think that communication piece seems really seamless for them. But again, they're sort of high education, savvy consumers, if you will, and sort of patients who follow directions well and use technology well. But this is really tough. People talk about like, oh, you're going to carry your records with you and do all this stuff, but just to go through things it's complicated.
Yeah.
Yeah, I think well, the system is fragmented and has always been. I'm not sure that all of the new entrants are necessarily contributing to a more cohesive system. But I do think that among a number of the primary care focused companies, that is the goal. Because everybody recognizes that when nobody owns the outcome, and yet nobody owns or at least is in complete control of care pathways, and yet value-based care and alternative payment models are starting to drive the conversation, because that's what's spurring a lot of these new companies. There is certainly a goal and an effort to get a little bit more control, if you will, over the total care of the patient, because the payment system is starting to incentivize that. Are we there yet at all? No, we're not. We've got a Medicare program, if you're not in Medicare Advantage, that allows you to seek and get care wherever you want. Attribution becomes a problem. Control, right, is the problem because you're not forced. And that is largely the case if you're not in an HMO. So I also, maybe I just feel like I've known this forever. I don't think that our electronic health record system is particularly interoperable, or well, it's not even a feeling. It's just not interoperable. You've got within health systems, tech and health record systems that don't talk to each other within the same hospital among separate departments. So we've got a long way to go, I think, in that way. But I do think that it is a stated goal, and you see a lot of investments trying to drive us in that direction.
Thank you. Ipsita or Limor, 30 seconds to weigh in before we close out.
I mean, I guess just on that primary care point, I don't even remember what the question was anymore, but I guess on the primary care point, for so long, primary care physicians have been so underpaid. And so I think what's interesting now is, United Health started doing this about a decade ago. They said, look, pay the docs more, the primary care docs more, that is. And then since they do control so much of the downstream care, and I like how Adez put it, there was never really anybody being paid to kind of own that patient and that outcome. Now you have those, full risk bearing, arrangements that allow for that. And, you can really participate in some upside if you are a physician group. And it's not the be all end all. And of course, it'll take time you know, and I talk to primary care docs through a lot of our work, and they're on average in 14 different relationships with these various groups, and there's all got different quality metrics. So it's not exactly a picnic for them either. But yeah, I think we're early innings on that front.
Okay. Leymore, I'm going to pass on you, and you can put something in the chat if you have anything, because we are right at time. And so I just would like to close this out by thanking the speakers today and for the attendees who've been with us for 3 days. I think they're rolling some slides here so we can give special thanks to our sponsors. There's too many to read. Thank you also to our conference planning committee and event production team. If you want to earn CME or CEU credit, be sure to complete the survey that you're going to receive by email. A link for the conference recording will be emailed to you after the conference, I think in a couple of weeks. The presentations will be available on the Whova app for 6 months. We will reconvene next year, February 23rd and 24th. And if you have any follow-up questions, please send them to Diane Ford at the Mirage School. And with that, I will just say goodbye to everyone. This is to my panel. You guys have been great, and this was a lot of fun. I hope you enjoyed it as well. And we'll see you next time.